That's the regrettable thing. There is no other way. And I think that when patients say they are having trouble with trazodone, and we have to do work with respect to the finessing the dosage, the dropping down the dose, or spacing it in installments and so on. There's almost nobody who is ultimately incapable of responding to serotonin. As a doctor, myself, takes the time and trouble to make it work for them. Yes?
Are they any closer to coming up with a test that can tell you how much serotonin?
No. Well, the problem is that the brain is covered, and this is the brain serotonin we're talking about. There's another serotonin that arises in the gut. The brain is covered by a curtain called the blood-brain barrier. And the blood-brain barrier doesn't allow things into the brain easily, and definitely doesn't allow the chemicals of the brain to get out to be measured. So there are indirect measures, but are not practical. I mean, they're very complicated and expensive, where you can get a hint that serotonin is less than it should be. Anybody else? Yes?
My question is regarding the whole concept of your program. Besides the trazodone, serotonin, there has to be some kind of dietary program as well. Could you just summarize that briefly?
Lana's here to answer that question.
Hello, everyone. It has to do with going on a low carbohydrate program in order to break one away from insulin resistance. People who are overweight will have a certain degree of insulin resistance. It can be very mild or it can be moderate. And this program is therapeutic because the foods that made you gain weight before, after coming out of the program, will not make you gain weight to the same degree. This is a low carbohydrate program, and they're not all created equal. This particular program actually suppresses the appetite via two ways, and one of them is serotonin. The other way is putting you in ketosis, and my goal is to keep you in ketosis in a very stable manner. In other programs, people are in and out of ketosis. They just cycle through it, and during the times that you're out of ketosis and you're keeping low carb, what happens is that your body does not get quite enough sugar for energy and is not then utilizing fat for energy when it's during the phases when it's not in ketosis, and so the body starts craving. Where my goal with you is to keep you in a very stable ketosis throughout the whole program. Ketosis simply is a fancy word that means to utilize your fat stores for energy. The body can use either sugar for energy or it can use ketones for energy, which is what I want your body to start utilizing. In that case, your fat stores will then be burned for energy, and that's what we want to happen.
So what is the general range? I know it's varied to individuals, but what is the range you seem to find is a good level for carbohydrate?
About 30 grams of carbohydrates a day, and I also will then very specifically lead you through how many carbohydrates per meal and per snacks. And basically, when you get to see me for guidance, the guidance is very, very specific. There's nothing general about it. I tell you exactly specifically which foods to buy. And there's no foods to buy from our program. We're not selling foods. We're just telling you, in fact, teaching you in the long run how to go to the regular stores and be able to, what to choose for yourself. And also, I really put a very, very big emphasis on maintenance. My patients get to see me a year from now and they still are maintaining the weight. That's what's very important to me. So, yes.
So, because it's based on ketosis,
yes.
How does this affect a person who's type 1, who is advised not
We do not put, that is what it's all about, because the patients get to see the doctor first before they get to see me, and from there I get their medical history. I'm a dietitian and I understand very well all kinds of different conditions. And so for someone who is type 1, obviously I would not put them in ketosis. In that case, the person is very likely on insulin, and so therefore we're going to go with higher carbohydrate amounts, and I can actually write out any program at all. It doesn't have to be specifically a ketogenic diet. That is why then, we will have a specific, very individual approach.
You have a question?
I fit the category of being the carboholic, but in addition to that, I suffer from obstructive sleep apnea and restless leg syndrome. And I take a medication at night because of the restless syndrome called
Ezrinmd, yeah.
And I sleep attached to a CPAP machine.
Well,
my question is this: with that medication, I never feel rested no matter how much sleep I get, even with the CPAP machine. Can I take this additional medication when?
Absolutely, absolutely. I think that you know how you can tell how well you've slept? Not when you wake up in the morning, where it's a little confusing, but in the day that follows. That is, if you have sustained energy from morning till evening, and if you also have a curbing of your carbohydrate cravings, these two symptoms are the way in which you tell whether you've got enough serotonin on board. We can't measure it in blood tests, but we can certainly tell that. And when you get the proper kind of deep sleep, we have people who come off CPAPs, who stop snoring, and who have remarkable increase in energy because of the improved quality of their sleep. Your batteries are more fully charged in the morning, and you have a rather remarkable day that follows. And this is the result of that good, deep level of restorative sleep, providing you with the serotonin that your brain lacks. And furthermore, this is not just simply a matter of taking the medicine until you've lost the weight. People who come to us have shown by their behavior and their condition that they have a deficit of serotonin. How much? We can't measure, but we know that when you get down to your goal weight and then you stop it, it may not be enough. I mean, you're going to relapse because you haven't done the necessary job of replenishing your empty reservoir in the brain, and you can't measure that. So I ask people to take trazodone for about 6 more months, or if their life is stressful, still longer than that, because stress is what's reducing the serotonin. And then, when the time is appropriate, slowly reducing the dose by maybe a quarter each month of what you're taking. And if you have no hint of a relapse, with no return of cravings or daytime fatigue, then you can say confidently that you've replenished your serotonin sufficiently that you no longer have to depend on the trazodone for the external supply. So this is not a simple matter of getting to your goal and way after they've lost the weight or headed for a disaster. They have to stay and work with us. And it's not that they have to come as often, but they still have to be in touch so that they don't lose sight of what's going on. Yes?
What approximately the cost of the program?
Well, the cost of the program, Judy, do you want to take that?
Pardon?
Somebody's asked the cost of the program.
Well, it's paid for by most medical insurance because it's not billed as a nutrition program. We just bill it under the physician.
How about if you are Kaiser member?
Unfortunately, we're not members of Kaiser. And so the cash price is $300 for the initial consultation and
And what
$100
again?
for the subsequent visits.
How much for subsequent care?
100.
Each
But if
visit
you're
is
of
100?
Medicare age, it's different. If you're of Medicare age, we do Medicare rates, but it's different every month. So you have to just call the office, and I'm just telling you what Medicare would charge for that.
Yes?
Excuse me, does it make sense to measure insulin level in patients who are overweight and who has normal blood sugar, so to speak, pre-diabetic range, and they have family history? Is it make sense to measure their insulin level to see that they indeed in high level of insulin?
Well, I do that routinely. I'm not sure that other doctors do, but I want to know what their insulin reserve is. In the first place, if they come overweight with a normal blood sugar, but with insulin maybe 3 or 4 times what we would have expected for that blood sugar, then they're called insulin resistant. And I think that if they are insulin resistant, then we have something to work with in the sense that by reducing their insulin and thereby liberating their stored fat. I don't know whether I had time to make the point that when people gain weight, and this is the way it works, they have an initial accumulation of fat in their abdomen. Now they can gain weight for a variety of reasons: depression, it can be inactivity, pregnancy, taking a medicine that stimulates the appetite, but it doesn't require much initial weight gain. It just needs about 15 or so pounds on the average to set in motion a process that has a life of its own. And what happens is that the fat that they accumulate is deposited primarily in the abdomen. Now, abdominal fat,